Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your co-host, Dr. Brittany Scruggs.
And I'm your co-host, Dr. Eric Bothan. We are here to bring you the latest and greatest in ophthalmology, medicine, and more. Today we are joined by Dr. Thomas Oetting, an ophthalmologist and educator at the University of Iowa who has shaped cataract surgery worldwide. Tune in to hear about his impressive career, his teaching philosophy, and his passion for surgical education, plus some fascinating insights into the future of ophthalmology.
Today, I'm excited to introduce our guest, Dr. Thomas Oetting. A leader in ophthalmology education, Dr. Oetting is a clinical professor of ophthalmology at the University of Iowa, where he has spent over 2 decades training future ophthalmologists. He's a recipient of numerous teaching awards, including many Iowa Resident Teaching Awards, the Asterisk Educator Award, the AAO-AUPO Stratsma Award, among many other awards for his career-long commitment to education and patient outcomes. He's also the co-founder and editor of iRounds, a vital resource for ophthalmic education. Along with his numerous courses and presentations, Dr. Oetting's passion for teaching has made him a mentor to more than 100 residents during his career. Dr. Oetting, welcome.
Well, thank you so much. I really appreciate the chance to at least see you virtually. We're so excited, Brittany, that you're there, and you seem like you're close enough for us to send patients to you at least, and we're so proud of you for all you've done in your career. And so thank you.
Yeah, we're glad you're here. And I do get some referrals from Iowa, and I send patients that way too. So it's a great relationship. But there are many things we want to talk to you about today. And thank you for joining us. Thank you for being one of my main mentors as a resident when I was at Iowa. So first, I thought we would start by just opening up the discussion about your journey. How did you get into ophthalmology, and specifically, how was the journey to ophthalmology education specifically?
Well, you know, my journey's like so many other folks. I think the technology of ophthalmology was interesting to me. I started off in engineering, and I worked in electrical engineering in the Air Force, and I went to grad school in engineering. But my wife, who was, right there with me, was in medical school, and I was just so interested in what she was doing. And so I just sort of made a switch and decided I was going to switch to medicine, and so I switched over. And but I still in the back of my mind was sort of how education was done, both in engineering and in the Air Force. And to be honest with you, I was pretty disappointed at first at how people were educated in medicine. I thought it was sort of random and not very structured. And so one of my missions when I started working here at the University of Iowa was to try to make things more structured. And what I mean by that is in the Air Force and in engineering in general, there's much more of a structure where you say to somebody, hey, here are the things you're going to learn today. Here's your goals for the day, or here's your goals for the week. And then the resources were so obviously centered on those goals. But the most interesting thing about it was the assessments were also focused on those goals. And so I found in medicine that a lot of times the goals were obtuse and not clear. You were never really sure what you're supposed to learn. You're never really sure what the agenda was. Sometimes the lectures that were given were just, some guy that you could drag up on the podium and give a talk because they were willing to give a talk, but it had less to do with sort of what your overall goals and objectives were. So one of the things I was trying to do was do that rare thing that works so well in education, where you line up your goals, your resources, and your assessments. And when you do that, education is so much easier and more fun and more sensical. And so I think my Air Force background, if anything, helped me more with that, I think. And so when I was training in surgery, you would just watch a case and then you would do the next case, and there was no way to really practice. There was very few video resources. We had one video that we sort of on a VHS tape that we sort of shared from person to person, and so it was very unstructured, and it was difficult. And to be honest with you, I never felt like it was safe. I always felt like that that what we were asking our patients to take too much risk in that environment. So anyway, that's kind of how I got started on this quest to try to make our educational program here at Iowa more safe for our patients, more structured. As a veteran, I was really interested in our veterans hospital. My father was a career military officer, and I spent some time in the military. And so I really wanted to come back and work at the VA. I wanted to make it safer. I wanted the training to be better. And so that was my sort of initial quest, my initial, why I came here.
When Brittany suggested you as our podcast guest, I was immediately struck by her excitement about you as a critical role and a mentor in her surgical training, and appreciating your passion for that. It's evident on how that's the case. Can you share, because she mentioned to me also about how your curriculum's become a global tool. Share. I want to get into residency training, but before we do, as we're talking about your career, tell me about this program in terms of starting out at Iowa, saying you wanted to build a better educational structure with rubric, with competence evaluations, with feedback. But what is this bigger curriculum?
Well, I mean, I think the secret, I think, to education is to try to have goals that are obtainable in a short amount of time, and then you build and build and build and build. And so I think one of the keys was to try to figure out how we could break down cataract surgery into parts that were manageable and parts that were obviously going to be achievable, and then work from that way forward. So, for example, one of the most important things is to know what the instruments are that you have available and what the names of those instruments are. And when I first got to the program at a VA, I just would ask our chief residents when they were leaving to name the instruments in our tray at the VA, and often they couldn't do it. And I thought, well, gosh, that sort of basic stuff is so important, but it was never clear to those amazing people that they needed to know this. They needed to sort of focus on some of this stuff. So just a simple thing like have a goal. The goal is I want you to be able to name all the instruments on the cataract tray, and I
And
want
there
you
is
to
an
be
instrument quiz that he developed,
Okay.
and it was actually kind of hard.
yeah. And so I think, but when you just say to somebody, "Hey, I just want you to know the instruments on the cataract tray," it sounds trivial, right? It sounds like something that everybody would know. But just building on things like that. So the goals you would have firm goals on what you want people to be able to do. So we had a process of things that were done in simulation, a process of things that were done by doing parts of cases, and a process of things that were done, by didactic sort of or video training or media training like the instruments. So if you ask residents in training that are young, early residents, and you say, "What's the hardest part of cataract surgery?" They'll often say that it's the rhexis. And so one of the things that we started, and I say we, I mean our program, we started the idea that we would just do the rhexis on some cases with our busiest surgeon, Dr. Johnson. And so the idea was we were going to deliberately practice this tricky part. And so the residents had already done a few cases, they'd already done some simulation, but they were going to, in the OR, just practice the rhexis with our busiest cataract surgeon. And so it did a couple things. By doing just parts of the case, it allowed him to not have a schedule that was totally screwed up by, this is a resident case, this is not a resident case. It just adds another 3 or 4 minutes to his case. Secondly, he developed an expertise in teaching, because teaching is also tricky. There's a learning curve for teaching. So he focused on teaching the rhexis, and And none of these cases counted towards the ACGME numbers, but who cares? Because the point is that they got to do a Rexus on about 100 cases with this surgeon who became quite expert at teaching how to do the Rexus. So by saying let's just pick one part of the case that we think is important, and we're going to deliberately practice this. We're going to focus our simulation training on that. We're gonna have didactic training on that, and we're gonna really take it seriously. The same kind of thing you would do if you were a fighter pilot instructor. You'd probably work really hard on how to land, right? Because eventually you want to go home and see your family. And so it's kind of the in our world of make believe for early surgeons, the Rexus is the hard part. And so we worked on that. So doing parts of cases, doing simulation, having a plan, having goals and objectives is the key to it. And I always think, well, what would be the thing if Brittany didn't know how to do something? What would I be so embarrassed if she didn't know how to do? And so if Brittany graduated from our program and couldn't do cataract surgery, I mean, I would be embarrassed. It would be like, that would be something that we should have done better. And so, yeah, I think every specialty you have to pick off what are the things that you really want them to be able to do. And then once you figure out what they are, those are your objectives. And then you say, how am I going to train them to do this? And so, like for you as a strabismus surgeon, maybe they have to know how to do a peritomy, or they have to know how to suture a muscle, and maybe those are the only two things. But you would be embarrassed if they didn't know how to do those two things, and so you come up with a program where you have opportunities for them to learn in the OR, opportunities to train in simulation, and
So it's been a few years since I've been in residency, so I don't know if things have changed. But one thing that was, I thought, pretty unique with the Iowa curriculum is when you think about cataract surgery, you think about grooving, taking out the lens, right, the crystalline lens. That's actually not what you start with. So in addition to the Rexus, you start by loading the lens and actually placing the lens. So it's more of like a back to start. So you start at the end and then you work your way up. So I don't know if that's something that you found was really effective, Dr. Oding, or how did you develop the curriculum in that way and starting with those steps?
yeah. So another interesting thing about when you look at cases, there's little parts of cases or little tasks that make up a case, and some of those are simpler than others. But the problem with cataract surgery is it builds. So if you make a crummy incision or make a crummy rexus or do a crummy nucleofractus, then the whole rest of the stuff that follows is more complicated. But if the whole beginning of the case is perfect, then those last parts of the case are often the simplest parts to learn on. And one of the overriding goals that we have for our surgeons is to be able to figure out how to use instruments inside the eye, how to know the AP depth in the eye, how to sort of work inside the eye. And so when you're learning how to work inside the eye, you want to do it at the safest part of the surgery so that your patient takes less risk. And so, as Brittany said, the best part is the end of the case because especially when you're just doing IA, and so that's the part of the case where IA is more prominent. The IA device is less likely to injure tissues inside the eye, and so while you're in there with just doing the eye, removing viscoelastic, for example, it's harder to damage the eye if you get off track, but you can still develop the skills of using that instrument in the eye. You move your hand up, the instrument goes down. You move your hand left, the instrument goes right. Putting the lens in is probably the simplest, especially now, is probably the simplest part of the procedure. However, you go home and tell your husband, hey, I put a lens in today, and all of a sudden, he was so skeptical about your future, and all of a sudden he's like, wow, Brittany's going to make some money for us. She can put lenses in. And then the other crazy thing about that is that when you do those little parts of the case at the end, all of a sudden, all the lectures that you've been bored watching, all the videos you didn't care about, all of a sudden become really interesting because you say, wow, this is a little trickier than I thought. This is more interesting than I thought. And so when you do that with junior residents, you incite some passion in them that is useful for fighting burnout. It's useful for getting them inspired about the work that we do to prepare. And so, yeah, backing in is a great way to train. And we stole this idea from Utah. Utah used to call it halvesies. So Utah would say to their junior residents, you want to do the beginning of the case or the end of the case? And so I just decided that the end of the case was much safer, probably better for the patient. So I just only offer the back of the case.
I echo that. When we review cases, we have a trauma video segment here, but whenever residents have meaningfully gotten into their anterior segment expertise, their amount of engagement and curiosity and appreciation, exponentially improves that way. You shared about simulation as part of this because you're being intentional about the core competencies at different pieces, the pieces that you really need to teach or you'll be embarrassed. Simulation has really been adopted in many or maybe most residency programs, in my understanding. Our residents here have a lab, the simulators. Share with us, in your understanding, what's the current introduction or how universal are cataract simulators, and is it true that most residencies have them? And when are residency programs getting the residents in the lab? Is it happening in the first year now? Is it the second year? What's the journey in residency prior to operating on a patient?
Well, I think simulators are super important, but I want to just make one point about them because I think there's a tendency to want to have a carnival, where everybody comes together, there's representatives everywhere, there's snacks outside the room, everyone is in there working. And the problem with the sort of carnival wet lab, although it's efficient for faculty and it's efficient for representatives of industry. But the problem with the carnival wet lab is all the people in there are not at the same level, right? So when you watch a carnival wet lab in a program, what you'll see is there are some people that are intensely interested. And those are the people that tomorrow are going to operate or this week are going to operate. And then you'll see people over in the corner that are like squirting each other with the IA, and they're like, "Oh wow, you can burn right in through the cornea with the phaco tip." They're just screwing around, and it's nothing wrong with those people. It's just that they're not going to operate for like 2 years, and so their interest in the wet lab is appropriately not high. They're worried about other things like how to refract or whatever. And so the way I think wet labs should go in a program is there should be a longitudinal wet lab. And by that I mean that there's one person or maybe two people that are in the mix and they are they're about to operate this week. And so what we do at our VA is the person that's going to do that backing in that Brittany mentioned, the person that's going to be doing the back part of the case, on the Monday before they go to the OR, they're in the wet lab with a faculty member during the daytime, and they are working on how to fold lenses. They're working on how to use the IA. They're working on how to push the pedals in a wet lab. And they're also working on suturing because in case the incision doesn't seal, they're going to be sitting there and I'm going to say, "Hey, are you ready to place a suture?" So, and then as the rotation progresses, they get more and more complicated in what they're doing in the wet lab. And then similarly, the person that's going to be doing the whole cases, when that rotation starts for them, we bring them to the wet lab and they do a whole case or two on a semi because they're now ready to bring all these things together and move forward. So the job, the training for each of your residents depends on where they are in the training program, right? Their desire to learn is going to be dependent on what's coming up next for them. And so we've always called this just-in-time learning. And the idea is that there's a cost to the inventory of what you learn. And so people appropriately will optimize. And so what you want to do is you want to have the simulation thing ready for the person when they are they need it. And so then they're going to get much more out of it, and the whole process is better. The other thing with simulation is if you have simulation that's at night or on the weekends, and you pick the junior faculty and say, hey, guess what your additional duty is? We're going to call you the vice chair for simulation, and we're going to have you come in weekends and nights, and we're not going to pay you any money, and you're going to be the simulation person. Those programs always fail, right? They fail for a couple reasons. Number one, they fail because you have shown the whole world that this is not important by making it night and weekends. So you've declared it's not important. I mean, you don't do the finance meeting for the chair doesn't happen nights and weekends. It happens during prime time, right? So the things that are important happen during prime time. And so what we were able to do at Iowa was we were able to get a slot for faculty to do it during the day so they can be a dedicated professional at simulation. And our person is this amazing Jackie Hogsdale. And and we've been able to get the resident out of clinic so that they can do it when they're rested. And then we've said this is just as important as clinic. It's just as important as the OR. The simulation is important. And once you make those few statements, then people say, "Well, okay, I'm going to take this seriously. I'm gonna really do this. I'm gonna take advantage of the tools." I was a visiting professor at this program. I'm not going to name the program, but I was up in their beautiful wet lab, and they had like an 8-station wet lab, beautiful view of the city. And I noticed that the wet lab was pristine, perfect. There was no eyeball
Wasn't being
juice.
used.
Exactly. There was no eyeball juice on anything. But the ping pong table had crud all over it. There was stains of food and beer or whatever. And so it was it was a startling because if you don't use the wet lab, it's worthless. And if you don't plan on how to use it with faculty support, using it during prime time, making it clear that there's a curriculum. So we have a curriculum for this wet lab. You can get online if you want. If you just Google Iowa Wet Lab, it'll come right up, and you can see this week by week curriculum you have for what your responsibilities are. And just like I was saying before, we have objectives, we have resources, and we have assessments in some cases as to what we expect during that time. And when you do that, it's very useful.
Yeah, so I have a question about transitioning from wet lab to maybe some early cases for residents. I think we all know as attendings that's stressful, right? To put it lightly, to be operating with people who maybe don't have the best control of their hands. And my question, I know you're a master educator. Everyone listening to this podcast, we all want to be better educators, but not everyone is as good as you are. And not everyone on this podcast listening is a cataract surgeon. So we have different types of surgeries and different teaching that we have to do. My question for you is, especially with the early residents when they're getting into the operating room, what are some key points for effective teaching for all of us, all attendings who are very much wanting to set their resident up for success?
Well, I think it's a great question. I think one of the great things that you could say came from the ACGME changing the criteria for surgery. So, for example, for now in retina, you don't actually have to do the whole case. So you just have to be present. That doesn't mean that there's not important things on retina or glaucoma or cornea for you to teach. It just means that it doesn't force you to have them do the whole case. And so what I would do if I were you is I would have the retina service work with the program director and say, what are the set of skills that you want us to teach during this time? They're not going to learn how to do vitrectomy, possibly, at least not a pars plana. They're not going to learn how to take care of little bitty children with eyes that are about 3 millimeters big. They're gonna learn other things. So you might say, you know what, we want to focus on, we're going to teach residents how to do a peritomy. We're going to teach residents how to close a peritomy. We're going to teach residents how to place a trocar. We're going to teach residents how to remove a trocar and place a suture. And that's it. That's all we're going to do. And then while we're doing vitrectomy, we're going to teach residents how to think about how to do an anterior vitrectomy. And I think if you just pick those three things, messing with the conjunctiva, putting in a trocar, and doing and understanding how to do an anterior vitrectomy while you're doing a pars plana, which they're not going to probably do. They could do it in some programs they learn how. And then you sequestered the job. And more than likely, these skills have already been done somewhere else, possibly. And these skills will be useful to the next rotation because if they do peds next, they want to know how to do peritomy. If they do peds next, they don't want to know how to suture the sclera. And so that's what I would do if I were you. I would not have an unrealistic goal that they're going to do a vitrectomy. I don't think that's important. I think the important thing is for them to know how to do a task, a subset, a part that you think is useful for their long-term goal of being a general ophthalmologist. And then, and then there's going to be some that'll come through that are like, wow, this person's so good. I think they could, like you were when you were a resident. That's so good that you would say, okay, well, Brittany can do a whole case of pars plana vitrectomy, and it will be useful to her future. But anyway, that's what I would do. I would just sequester it. And just for every subspecialty, there are things that are useful to every ophthalmologist. And then the thing that I think is important, and I'm sure that you guys have encountered this already, but when I was training, I did all extra caps, right? I didn't learn how to do phaco as a resident, or barely learned it. So I had to teach it myself. So what I was learning was skills. I was learning how to manipulate conjunctiva, how to make an incision, how to suture, how to work inside the eye. And so these skills are transferable no matter how the technology changes with time. And so you're teaching how to manipulate tissue. You're teaching how to go inside the eye and get outside of the eye. Again, you're teaching, is the eye closed at the end? Is everything okay at the end? And then you can use this time. I don't know if there are some. I can imagine that there's some times that you could chit chat about how to do a vet or something. You could use it as an opportunity for didactic training. Anyway, that's what I would do if I were you.
I like the understanding and appreciation that skills from one area complement another or equip you to develop new skills. You were residency director at one point, and as you have appreciated the vital role of having these intentional, focused steps in the journey of cataract training, how does that affect your residency director role for all services? Is there a cross-pollination where now you've changed your curriculum in the strabismus program or in doing glaucoma surgery? At Iowa, do you feel like that journey and leadership you've learned in cataract has affected other areas? And what would you advise for other residency directors trying to improve their programs?
Well, I do think that that we tend to operate in silos. We tend to not work together as much as we could. And I do think that the more we can sort of come up with a set of skills that we want people to have by the time they leave, and then partition those skills and work together, the better off we'll be. Um, and so I think that's one of the jobs of the program director. I would like to say one story in the context of program director because Brittany's sitting right over there. When my children, I was mentioning to you earlier that my children are now 30 through 35. And when I was starting as a program director, my children were in various jobs. And I was kind of shocked by the amount of responsibility that they had early and then the amount of independence that they had early. Um, and I was when I was a resident, I was always kind of surprised by how everyone was kind of treated in sort of a juvenile way in some senses compared to when I was in the Air Force. That there was a sense that you weren't supposed to think too much on your own. And so, but when Brittany came in, she had this incredible research career before she came, and I was thinking about my children, how in one of their companies they were all given these little weekly mini sabbaticals where they were allowed to do whatever they wanted for a half day. So I think one of the most powerful things that we did in our residency was we started this thing called Captain of Your Ship time, and it was really we should have dedicated it more to Brittany because the idea came because I wanted to make sure she had the ability to do this. But the idea was that for a half day every other week or so, you could do whatever you wanted. And what I wanted to do was I wanted to respect the amazing people that we had coming in, and I wanted them to have time to do things they thought were important. Now, for some people, it could be something like
Going to the
um,
dentist.
going to the dentist or counseling, or it could be doing push-ups or whatever. For some people, like Brittany, it was a series of unbelievable research projects. And because then she could, during the week, have access to researchers and statisticians and so forth. But I think one of the mistakes we make is if our training is going to be so long, I think it's too long. But if our training is going to be so long, then we need to not uh, kill the part of our trainees that is so special. And so anyway, as a result of this this project that we started uh, when during Brittany's time, we've had some unbelievable projects that would have never been able to proceed without this access to daytime um, uh, energy, or whatever you want to call it. Um, and and so that's the thing I would encourage programs to do. I would encourage programs to to try to not kill the the amazing people that are coming in with 100% service mundane activities, and give them, because it'll help your department more than you can imagine. I mean, you're going to get all kinds of cool fame, and believe it, we took total credit for all of Brittany's projects. I was told not to mention them on this podcast because they're our projects, they're not hers. But the truth of the matter is, they were her projects.
It's wonderful to appreciate that priority, not just in education and structure, but also the priority in how you structure time for your residents. And residency programs and directors always try to do that better, but these are wonderful examples of creative things to complement the learner.
Yeah. I'm going to give an example of what I was allowed to do, and it wasn't a me thing. Worked with amazing like giants in the field during that time of your captain of your ship time. As a resident, I was able to assist on 70 pig vitrectomies with multiple different staff, Dr. Elliot Sohn, Dr. Ian Hahn, amazing surgeons. And that gave me extra surgical experience as an assistant, but also set up my career as a pig surgeon, which is, as you know, my main model now. I don't think I would have had the confidence to do this as a career and have the knowledge and expertise to start my own lab with pig surgery if I didn't have that time at Iowa. That also gives you time to like grow cells. You know, as a scientist, like you need that time during the day and go to lab meetings. And thank you, Dr. Oeding. Like seriously, thank you for listening to your residents. Thank you for empowering them and providing them with the people and the resources, because I'm not sure that I would be the clinician, surgeon, scientist today if that had not been the case. So I very much appreciate it.
We only have about 5 more minutes. I just want to touch on another subject in education, and that's just how our technologies have changed. I've heard a variety of feedbacks of flipped classrooms and virtual learning, and it's an interesting environment that's sometimes hard to get everybody in person for department meetings or whatever it might be. Share with us your appreciation for opportunities and or challenges for how the virtual learning environment affects residency training or your department.
Yeah, I do think it's a dual-edged sword. I think the problem with virtual learning is that to a certain extent it damages our culture and our ability to get together. I love the idea of aligning your objectives and resources by putting things online that are sort of your favorite videos or your lectures. I think that's very efficient. I do think, though, that the relationships that we develop with each other are so important for when the sea gets shaky during the stormy times. And so the only way you can really do that is by having activities where you're all together. And so you can do that with social things. You can do it by having lectures where everyone gets together. You can, but don't don't set up a program where everything's virtual and no one's all together, because what's going to happen is in every program or every organization, not just residency programs, there's going to be times when one person has trouble. They're out, they're sick, they have a baby, their parent gets sick or something. Um, and and the thing that 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 helps an organization is to know each other so well in other times. Like you guys last night, I guess at Mayo had a get together, a real live get together where you all hang out. And I think that's so important. And one of the ways you do that is with rounds, and one of the ways you do that is with lectures. And so I think when you do a flipped classroom, I think the beauty of it is if you say, okay, we're going to cut down the time of lectures from 2 hours to 1 hour, but the 1 hour that we're not doing it anymore is not going to become clinic. It's going to be either you sleep in, or that's the time you look at videos or whatever. Because the danger of having these virtual things is that all of a sudden you say, well, just look at it at night and weekends, and we no longer have time during the week where we're dedicated to do that kind of stuff. So people's connections with each other go down. The overall time that people have to do stuff goes down. And so that's the danger of the flipped classroom. But if you do the flipped classroom where you say, okay, we did have 5 hours scheduled for our content, we're going to only have 2 hours together, but it's going to be really good time. We're going to ask questions of each other. We're going to get together. We're going to talk. We're going to be with each other, and we're going to talk about the things that you saw in those videos. Then I think that's useful. I think overall that the net of that is a gain, but you just have to be careful.
I have a question, if that's okay.
Yeah.
I think we have a few more minutes. So my question is regarding like the journey of cataract surgery and how advances have happened. You said that you started with extra caps and now you're doing very complex cataract surgery that's completely different than how you were trained. So my question is, what is one of the advances of cataract surgery that you think is one of the best things that's happened since cataract surgery, like since you've learned cataract surgery? And then also, what are you looking forward to? Something that maybe is to come that you're really excited about?
Well, I think there's some one of the mundane but really powerful things that came was capsular stains, and it's going to sound so boring to you, but it changed so much for us. It allowed us to do complicated cataracts and see what was going on. It allowed us to let more junior people operate on those cases, which is nice. It also, some programs use capsular stain so people can see the rexus better while they're learning how to do the rexus, which is useful. So to me, I think that's one of the big ones. I think the thing that's really crazy is that the ability to put the lenses in has become so trivial now, because you just push a button on the Alcon device, for example, and the lens goes in. So putting a lens in used to be a big deal. It used to be hard to put it in. The three-piece would flip out. It would come out fast. And so there was a set of things that we worried about before that we don't worry about anymore. And I think that's been a big change for us. The machines have gotten better and safer, and I think that's good. But I think the big thing that's coming probably is some kind of robotic surgery. And there's a couple companies that are working on that, and I think Alcon invested in one of those companies, and so I think that will be an interesting possible paradigm shift for us, where we're not holding the actual instruments that are inside the eye, but we're holding something that's holding those instruments. We're holding onto a robot, and I think maybe for cataract surgery that will not be as important, but it certainly might be important for your very delicate surgery in retina, or for doing injections in retina. And I think so. Manipulating devices that are connected electronically to a device that's connected to the eye, I think is gonna be an interesting twist. Um, and then I think from a learning point of view, we've got this crazy thing happening with AI. So already there are there are ChatGPT and others are already much smarter than me. They're nipping on your heels, Brittany. I'm telling you, they're coming.
Noted.
And so we're gonna have to figure out what we teach and what we don't teach. We're gonna have to figure out how we use these devices, how we partner with this technology. I mean, we don't really care anymore, what stain you use for some a biopsy, right? I mean, we're just going to look it up. We're not going to memorize that. And so, how are we going to change our process in testing residents? How are we going to change our process in how we team up together? And it was a very similar to when the internet came out. We resented the internet. Neither of you guys are probably old enough to remember this, but when the internet first came out, we totally resented it. We tell residents not to use the internet. It's not a good source. I did a couple papers on it years ago, and I mean, and obviously now it's just part of our lives, and I think this is going to be part of our lives, and we're going to have to figure out how we maintain our our ability to lead and go forward with this technology, and I think that's going to be fun and interesting.
Well, Dr. Oetting, I just certainly appreciate the enthusiasm that Brittany had before as someone in Iowa that's a master educator and appreciated by your residents, but certainly recognized and appreciated nationally and globally for the priority, the leadership, and the passion to help our learners learn better and advance our field. So I thank you for the gift of sharing your time with us today and sharing your insights in this field.
Yeah, I just want to say thank you for being here and for being a mentor to so many, including myself. I do want to end with what I hear in my mind when I'm training other people. It's out of the eye, ma'am.
Well, yeah, I grew up in the South, so everybody's ma'am or sir.
Yeah.
I
I
think
hear
we
you,
all have our mentor voices, and those
Out of the eye,
voices
man.
are so dear to us and important. So thank you
Thank
for being
you.
a voice into the next generation of ophthalmologists.
Hey, thank you both. I appreciate it. It's nice seeing you all. Thank you.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website, YouTube, or on most podcast platforms.
Thank you for listening, and we definitely look forward to sharing more on our next podcast.